Very good morning. I welcome you to this instruction course. This is one of the instruction courses that we have been regularly doing over last couple of AIOS. Instruction course which is from multi-speciality or super specialty doctors who would like to give a few tips to their anterior segment friends and colleagues on how to manage their complex cases a little better. I would like to acknowledge and thank Dr. Avninder Gupta sir for designing this course, being the mentor for all of us on this course, and quite a few innovations are from his mind, I would say, and slowly then have been taken over by us on at Center for Sight. And I would now request Dr. Avninder Gupta to initiate the course, and then I'll go on with the first presentation.
Uh, uh, he'll be speaking about vitreous decompression in cataract surgery with shallow AC. Actually, this is an instruction course where anterior segment surgeons have come to us with various problems, and we have tried to help anterior segment surgeon to make their surgery easy. This technique of vitreous decompression actually was discovered with Dr. Hirsch and Dr. Ritika, because Dr. Hirsch comes with always comes ki the pressure is not coming down. I have given mannitol to the patient, and still patient 40. I'll open the eye, and most probably it will lead to sudden hypotony leading to expulsive hemorrhage. So we said ki yes, we'll do slow decompression of the posterior segment and reduce the intraocular pressure. That way your chamber will also decrease, and your surgery will also become easier. We had an phacomorphic glaucoma, and that Ritesh will highlight in his talk, and we helped our anterior segment to do the nice job with minimal complication. And I think Hemlata and all anterior segment, one of the most prolific surgeons of our center, is using this technique. The main thing is ki if we are able to influence our best of the surgeons that this technique will help them, that means we are successful in that. And we have two of the best surgeons from two different specialities, Dr. Hirsch and Dr. Hemlata, adapting to this technique. That means this technique is helpful. Dr. Ritesh will speak on vitreous decompression. Important thing, one thing what I like, all the techniques involve trocar and cannula systems. So a brief introduction about trocar and cannula systems will be given by Dr. Ritesh.
Thank you, Dr. Gupta. So I'll introduce the hero of this instruction course. Can I have my slides? Yeah. So the hero of this instruction course is our trocar cannula system, which comes to the rescue, especially in the initial few techniques that we are going to be showing. 23-gauge micro-incision trocar cannula system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of three 23-gauge trocar cannulas, an infusion pipe, and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use. it is a relatively simple technique which can be mastered easily with little practice. Now coming on to the first talk of this IC, that is vitreous decompression. As Dr. Gupta rightly pointed out, it's a technique which has picked up over a period of time. Now we have regularly in our OT list surgeons asking for pre-planned vitreous decompression for their tough surgeries. So what is vitreous decompression? We know phacoemulsification for anterior segment surgeon in shallow, crowded anterior chambers is a challenging situation. This is commonly encountered by them in intumescent cataracts, in cases of phacomorphic glaucoma, hypermetropes, small eyes, or in cataracts in eyes with pre-existing glaucoma. And the problem in these cases is that when they undergo phacoemulsification, it leads to a lot more endothelial compromise. The chamber is very shallow. It's difficult to perform the surgery. There is a risk of descendant detachment. The capsulorhexis very often can extend if there is a lot of upthrust coming from behind, and zonular dialysis, vitreous loss, causing because of PC rent, iris prolapse, and all. And the more worst of situations, you can land up with even expulsive choroidal hemorrhage. So keeping all this in mind, it is a standard practice to kind of decompress these eyes. So earlier what was being used, what is generally done is a controlled paracentesis is done, a lot of viscoelastic is injected. IV mannitol is used to contract the vitreous so that the upthrust can go down, but these generally, what we have seen may not work in all cases. So then what all could have been done? So what has been advised in literature is you can do a direct vitreous tap with a needle. You can do a vitreous tap with a needle aspiration. Some people also recommend going directly into the lens, aspirating the lens matter, especially if the lens is intumescent, a lot of liquefied lens matter is there. Or you can even do a partial pars plana core vitrectomy. But all these procedures done blind are fraught with a lot of risk. There is a risk of complication, detachment, vitreous pull, vitreous. Uh, so all these can lead to a lot of tricky situations. So we came up with this technique. This was a video of an 86-year-old female who had presented to us with an advanced cataract. 10 days ago, she had been advised somewhere else to go for surgery. It was a phacomorphic glaucoma. Preoperatively, she was prepared with mannitol, topical anti-glaucomas, but the pressures were very high on the day of surgery. So what we did was we put a trocar cannula 3.5 mm behind the limbus, and we just left it open. Most of these patients are elderly patients. The vitreous is liquefied, and it tends to prolapse out of these non-valved cannula. And then now using a cutter at high cut rate, low suction, without causing any pull on the vitreous which is prolapsing out is gently just cut at the level of the opening of the cutter. It causes the pressure to go down significantly. The anterior segment surgeon very easily is able to now maneuver their instruments in the eye, able to carry on a good rhexis, which otherwise in a high pressure situation with a lot of upthrust is not very easy to do. And a comfortable phacoemulsification can be done in situations like this. So as you can see here now, our anterior segment colleague has started doing phacoemulsification. The beauty of this procedure is that if at any stage during the middle of the surgery you again find the thrust going up, like now in this particular situation, there was again an upthrust and there was a small iris prolapse happening. That means the pressure was high again. You can open the trocar again. You can keep it blocked with a plug. You can open the trocar again, allow a little more vitreous to decompress out, do more vitrectomy at the opening, get the pressures down so that the surgeon can complete his phacoemulsification much more safely and comfortably. And that's the surgery being completed and the IOL being inserted and the wound secured, and in the end the trocar is just removed with a slight pressure onto the port. So in a tricky situation, also with the help of a trocar cannula system and vitreous decompression, one is able to carry on these surgeries in a much more safer manner, in a much more controlled manner without any risk of complications. Thank you.
Very nicely elucidated. experiences of Dr. Ritesh. One thing is very important here, that you don't use valve cannulas, because if you use valve cannulas, then you will have to go inside, and there won't be any prolapse of vitreous or liquefied vitreous from the posterior chamber outside. So non-valve cannula is a must. Any questions from the audience?
So, so I would prefer a 23 gauge. It gives an advantage of it being a cannula, so a sutureless entry exit, but at the same time have a good enough a bore to allow for enough liquefied vitreous to prolapse out. A 25-27 valved may not be the ideal choice for these situations. And see, these 23 gauge Crowcar cannulas are available easily. They are quite cheap, easily available, and can be purchased standalone. You need not purchase the whole packs for this.
Uh, vitreous will not come in 27 and 25.
Yeah,
20,
25-27
yeah.
is not okay.
Gel vitreous won't come
It's
out.
too small an opening.
And second thing, with decrease in intraocular pressure, there is an advantage that rhexis will not extend. So you will be able to perform rhexis, although many surgeons will say, "Okay, I'll do a femtorhexis," but if femto laser is not available, if you have a very shallow anti-A chamber, in cases of hypermetrope, mature cataracts, uh, hypermature cataract, phacomorphic glaucoma, this technique